Welcome to a new HumanX medical case study. Today, we're examining a common yet critical condition, an aortic valve stenosis. Our patient is an 84-year-old woman who has been experiencing symptoms that significantly impact her daily life. Shortness of breath during activity, fatigue, and even difficulty walking short distances. To address this, the cardiovascular surgical team has planned a transcatheter aortic valve replacement, or TAVR. This minimally invasive procedure replaces the narrowed aortic valve, restoring proper blood flow and alleviating the patient's symptoms. Let's take a closer look at how the TAVR procedure is performed. A catheter is inserted into the femoral artery in the leg and guided to the heart. A replacement valve is then delivered through the catheter and placed in the heart. A balloon on the catheter tip inflates to press the new valve into place. This approach reduces surgical trauma, making it an ideal choice for elderly patients. The TAVR procedure is challenging because the aortic valve cannot be viewed directly, as it would be with an open surgical procedure. The surgical team only uses X-ray and ultrasound to position the new artificial aortic valve. Therefore, it is very important to have a good understanding of the patient's anatomical situation. Now, let's move to the patient's CT images. These provide detailed insights into the anatomy and the severity of the stenosis. Note the calcifications on the valve leaflets and the restricted opening that has led to her symptoms. Understanding these details is critical for planning the procedure and selecting the appropriate valve size. The pictures shown here are from the systolic phase of the heart. They represent the maximum opening of the heart valve while the ventricle is pumping the blood into the aorta. Feel free to pause the video to have a closer look at the images. To help prepare for the intervention, the cardiovascular surgical team requested a patient-specific heart model. The requirements were precise: a 1-to-1 representation of the structures of the left heart, including the left ventricle, the mitral valve, the aortic root, and the ascending aorta. In addition, the model had to be modular and allow access to the left ventricle to view the aortic valve from the inside. Soft and flexible materials were required to replicate the feel of real tissue. Our HumanX score for 3D modeling and printing shows that the model is not so easy to print. The material requirements and the flexibility must be taken into account when setting up the print job. The segmentation of the different structures is challenging and requires a good knowledge of the anatomy of the human heart and its representation on CT images. With this first analysis complete, the stage is set for creating a patient-specific model to aid in surgical planning and practice. In a first step, we are segmenting the structures of interest from the patient's CT scan. This crucial step lays the foundation for creating an accurate and detailed patient-specific heart model. As you can see in the rendering preview, many other structures are visible with the same threshold values as the heart. We begin by cropping the CT volume to focus exclusively on the heart. This reduces unnecessary data and ensures clarity in the segmentation process. The cropped volume has a layer spacing of 0.5 mm, which provides excellent resolution for capturing all details of the heart structures. Next, we create 9 different labels, each representing a specific anatomical structure. These include the left and right ventricle, the aorta, left and right atrium, and other important structures. By assigning labels, we can precisely differentiate and segment these areas. For the actual segmentation, we use the Grow from Seeds algorithm. Instead of highlighting every layer of the CT scan, we mark the structures on selected layers. This approach saves time while maintaining accuracy. Once the algorithm is executed, we carefully review and adjust the segmentation to ensure that all structures are properly defined. The final step in this process is transforming the segmented labels into digital 3D models. These models are the building blocks for creating the patient-specific heart replica, setting the stage for the next steps in our workflow. To make the model ready for 3D printing, we are switching to another software. In this step, we use the software Mesh Mixer to transform the segmented digital 3D files into a model ready for 3D printing. This process is essential for ensuring that the heart model is both accurate and structurally sound for printing. The first goal is to eliminate any internal errors within the files. Common issues include holes in the mesh or separated structures, also known as islands. These errors can compromise the quality of the printed model and must be addressed carefully. We also focus on refining the surface of the model. Using the smoothing and cleaning tools in Mesh Mixer, we enhance the surface to mimic the appearance of heart tissue. This step not only improves the model's aesthetic, but also ensures that it accurately represents the anatomical structures for surgical planning and training. It's important to note that most of the segmented structures represent only the inner lumen of the heart's cavities. These cavities are made visible in the CT scan by the contrast agent introduced during imaging. While this provides a detailed view of the internal anatomy, it requires careful modeling to create an accurate and realistic 3D printable structure. Additionally, the final digital model is tailored to meet the specific requirements outlined by the surgeons. It provides a one-to-one representation of the left heart structures, including the left ventricle, mitral valve, aortic root, and ascending aorta. The model's modular design enables direct access to the left ventricle. This feature ensures the aortic valve can be viewed and evaluated from within the ventricle, meeting the physician's need for a detailed, hands-on approach to test and practice the procedure. By the end of this process, we've created a clean, smooth, and printable model that fulfills these exacting requirements and is ready for the next stage in our workflow, preparing it for 3D printing. Before we move on to 3D printing, we have to validate the digital 3D model to ensure it accurately represents the patient's anatomy as captured in the CT scan. This additional step is crucial to confirm that the final model is a precise, one-to-one replica of the original DICOM data. To perform this validation, we re-import the finalized STL model into 3D Slicer, the same software used during the segmentation process. By overlaying the 3D model onto the CT images, we can compare them layer by layer. This allows us to visually confirm the alignment and identify any discrepancies between the model and the scan. The results show high accuracy. Each structure matches perfectly with the CT data. It's important to note that the maximum level of detail achievable in the model is determined by the layer spacing of the original CT scan. In this case, the 0.5 mm layer spacing allows for a very high-resolution model, but details smaller than this threshold cannot be captured. The next step is bringing the digital model to life through 3D printing. For this, we use digital light processing, or DLP, technology. This method is ideal for creating highly detailed anatomical models. DLP is a resin-based 3D printing process that utilizes a photosensitive resin stored in a tank. A high-resolution light source selectively cures the resin layer by layer, solidifying the material to form the model. This approach ensures exceptional precision, perfectly capturing even the smallest anatomical details. In this case, we chose a resin that cures to a flexible material with a hardness of Shore A30. This material not only meets the surgeon's requirements for flexibility but also provides the durability needed for handling and testing. Let's have a look at the final models. In addition to the main model, we also printed the aortic root as a single part. As you can see, the 3D printed models provide a detailed representation of the patient's pathological situation. The two parts of the left ventricle can be combined without a visual gap. The flexibility of the material enables the simulation of the balloon inflation and valve placement. To sum up this case study, let's recap the steps involved in creating the patient-specific heart model. We began by analyzing the CT scan to identify and segment the anatomical structures of interest. Together with the 3D modeling process, it took us around 5 hours to create a digital copy of the anatomical structures. The final design was validated by overlaying it with the original CT images, confirming a 1-to-1 correspondence. 3D printing took a little bit over 6 hours. In just 12 hours, this process resulted in a model that perfectly met the surgeon's requirements. As they reported, the model illustrated the anatomical situation and the significant stenosis of the aortic valve. The position and guidance of the catheter and the artificial aortic valve could be demonstrated and reviewed on the model, providing better understanding for everyone involved. If you have enjoyed this case study, don't forget to like and subscribe. And if you have an interesting case you'd like us to cover, let us know in the comments, we'd love to hear from you. Thank you for watching, and we'll see you in the next episode.